Welcome to Energy Expenditure, a presentation on measured and estimated energy expenditure during acute and critical illness. First, let's review the basic components of energy expenditure. The components of energy expenditure are dependent on a variety of factors, including lean body mass, age, and gender, each of which impacts the basal metabolic rate. This accounts for the majority of energy expenditure. However, there are other factors that may impact energy utilization, including diet-induced thermogenesis, physical activity, and unmeasurable losses. Components of total energy expenditure, or TEE, will be further discussed in the following slide. Total energy expenditure over a 24-hour period of time is a sum of several components, including resting energy expenditure, REE, also known as resting metabolic rate or basal metabolic rate, which typically accounts for 60 to 75% of energy expenditure. This is defined as the lowest energy expenditure calculated from oxygen consumption measured over 6 to 12 minutes when the subject is lying in a stable state, meaning nothing by mouth for 12 hours, resting for at least 30 minutes in a thermally neutral environment prior to the exam. To achieve the most accurate reflection of a basal metabolic rate, the measurement should be obtained during the early morning hours of deep sleep. However, this is impractical in most settings, therefore the results are typically considered to be measures of resting energy expenditure as opposed to basal. The next component of TEE is diet-induced thermogenesis, also known as the thermic effect of food. This accounts for 10 to 15% of total energy expenditure. It accounts for the dynamic action of food and is increased following food or beverage consumption, accounting for the cost of nutrient absorption, transport, storage, and metabolism. Both the thermic effect of physical activity or exercise and the thermic effect of disease or injury can greatly vary from person to person. Physical activity accounts for 5 to 10% of energy expenditure in the typical adult, but is much higher among high-performance athletes due to energy expended for muscular work. Thermic effect of disease or injury also varies not only by individual but by severity of disease or injury. This can change greatly throughout stages of illness and should be continuously assessed by the clinician to most appropriately provide nutrition support. The majority of this presentation will cover energy expenditure, methods for determining, and complications with inappropriate delivery of nutrition among the acute and critically ill population. Acute and critically ill patients often experience high levels of metabolic stress and inflammation, which, combined with malnutrition, either of critical illness or pre-existing state, have been associated with higher healthcare costs and negative outcomes. Research indicates respiratory muscle strength declines after only a few days of inadequate nutrition. Additionally, underfed patients have been found to have higher rates of ventilatory dependence, longer lengths of stay in the intensive care unit, and a 2.1-fold increase in pressure ulcer development, as well as higher rates of mortality. Other researchers have determined that adequate nutrition delivery correlates with fewer days on mechanical ventilation and reduced ICU lengths of stay. Numerous researchers have examined complications of inappropriate nutrition support, both under and overfeeding. Overfeeding has been associated with azotemia, hepatic steatosis, hypertriglyceridemia, immunocompromise, a hyperosmolar state, hyperglycemia, fluid overload, and hypercapnia, while underfeeding has been associated with immunosuppression, loss of lean body mass, prolonged hospitalization, suboptimal wound healing, nosocomial infections, respiratory muscle weakness, and prolonged mechanical ventilation. To prevent complications associated with both under and overfeeding, it's imperative to accurately assess energy requirements. Assessment of energy requirement is most commonly achieved through the use of predictive equations due to ease of calculation, reduced time and costs associated with equations compared to obtaining measurements of actual energy expenditure, such as indirect calorimetry. Let's review methods for determining energy requirements. Predictive equations are the most common method for determining energy requirements. There may be as many as 200 variations of equations in use, each of which was derived from a very specific population. These equations use readily available data such as anthropometrics, age, sex, as well as stress and activity factors, temperature, and measures of ventilation. There are a large and varying number of factors that limit generalizability of each one of these equations. It's important to remember that equations are estimates of energy expenditure as opposed to measurements. And as the number of variables in each equation increase, there's an increased risk for bias and transcription error. Furthermore, the more variables in the equation, the more chance that a small change in any one of these variables may impact the accuracy of the equation. For this reason, predictive equations should only be used for the population in which each equation was derived. This table provides an overview of some of the most commonly used predictive equations, the population from which each equation was derived, as well as the data required to complete the equation. As you can see, populations range from healthy adults in the early 1900s to multiple trauma patients of the late 1990s. Please take a moment to examine differences in each one of these equations. Due to complexity of many of the predictive equations, clinicians often use the calorie per kilo method to estimate energy requirements. For this method, a baseline assessment of weight status classified by body mass index, underweight, normal weight, or overweight or obese, is generally used to determine the calories per kilo, as depicted in the chart above. When an individual weighs greater than 120% of his or her ideal body weight, adjusted weight is calculated and utilized to dose calories. Adjusted weight is calculated assuming that 25% of the excessive mass is metabolically active, while the remaining 75% is fat mass. Calories should not be prescribed to feed this excess fat mass weight. The calculation for adjusted weight is presented on this slide. Predictive equations, though easy to use, are not without limitations. Most are derived using a regression analysis from measurements obtained by indirect calorimetry. Due to differences in patient populations and limited generalizability of each equation, they should only be used to determine energy requirements for the population in which the equation was derived. Predictive equations have a large amount of individual variation in estimation of energy expenditure, with a large range of error, 7 to 55%. Factors impacting range include anthropometrics, age, health status, activity, and accuracy of data and transcription. Measured energy expenditure is a more accurate method for determining energy requirements. There are various methods for measuring energy expenditure. Direct calorimetry is the measure of heat output. A special chamber is used to measure heat given off by the subject through radiation, convection, and evaporation. Direct calorimeters range in size from a chamber just large enough to fit the size of a subject to whole room chambers. The walls of direct calorimeters typically contain water layers that are warmed by the subject's body heat. Changes in water temperature are recorded, allowing for calculation of energy expenditure. More complex chambers may also measure temperature, pressure, humidity, motion, and the composition of air entering and exiting the chamber. That is then analyzed to determine carbon dioxide and methane production, as well as oxygen consumption. Indirect calorimetry is based on the notion that energy metabolism is dependent on oxygen utilization and carbon dioxide production. Expired air contains less oxygen than inspired air. When the volume of inspired and expired air is known, the difference in oxygen and carbon dioxide concentrations can be calculated. This is extrapolated into energy expenditure. Estimation of energy expenditure by indirect calorimetry has been found to be nearly identical to those derived from direct calorimetry. This will be discussed on further slides. Energy expenditure can also be measured via ingestion of doubly labeled water. During this test, the subject drinks a known amount of two stable isotopic forms of water. These isotopic waters mix with the body water and are gradually eliminated. Over 1 to 3 weeks, a series of urine samples are collected to measure the rate at which the two isotopes disappear from the body. Measurement of energy expenditure via doubly labeled water has been found to have an accuracy of 1% and a coefficient of variation of between 3 and 6%. It may be the best available method for providing an average estimate of 24-hour energy expenditure over 1 to 3 weeks. However, it is not a direct measurement of energy expenditure. Lastly, the bicarbonate urea method measures total energy expenditure in free living subjects over a short period of time. Indirect calorimetry is the most commonly used method for measuring energy expenditure. This method relies on estimates of carbon dioxide gold standard for determining energy requirements among acute and critically ill populations. Carbon-containing isotopes are administered. It is important to understand the information obtained from indirect calorimetry labeled carbon is eliminated both through IC measurements yield three important values: urea in the urine, resting energy expenditure, the amount of labeled carbon in the urea. It is the measure of energy expenditure in calories per day, or Kcal per day. The respiratory quotient, or RQ, which is the measure of substrate utilization, and the coefficient of variation, or CV, which is a measure of variance between breaths expressed as a percentage. Understanding the basics behind indirect calorimetry will help you better understand the results. Human energy expenditure is the release of chemical energy stored in nutrients. In the presence of oxygen, nutrients, i.e. substrates, are converted into carbon dioxide, water, and heat. Indirect calorimetry measures pulmonary gas exchange, VO2 consumption or oxygen consumption, and VCO2 or carbon dioxide excretion expressed in milliliters per minute. IC assesses substrate utilization, i.e. nutrient type, and byproduct production. Energy is then calculated by measuring the amount of oxygen used and carbon dioxide produced. After determining VCO2 production and VO2 consumption, total average daily energy expenditure expressed in Kcal per day can be calculated using the Weir equation, as seen at the top of this slide. Note this equation utilizes urinary nitrogen. Urinary nitrogen collection is often difficult to obtain accurately in the clinical setting. Therefore, a modified version of the Weir equation has been produced. This is what's typically used by indirect calorimeters to determine resting energy expenditure, as excluding urinary nitrogen only results in a small error in calculation, only 1 to 2%, which is not clinically significant. VO2 and VCO2 are used to calculate the respiratory quotient, which is the ratio of carbon dioxide excretion to oxygen consumption. During ideal conditions, the respiratory quotient may reflect substrate utilization. The RQ of glucose oxidation is 1, where the oxygen consumption and carbon dioxide production are equal. The RQ of protein is 0.81, where the oxygen consumption is greater than carbon dioxide production. The RQ of lipid is 0.69, where oxygen consumption is 1.4 times higher than that of carbon dioxide production. An RQ of 0.85 reflects mixed fuel burning, whereas greater than 1 reflects lipogenesis and less than 0.7 reflects ketogenesis. Physiologic normal ranges for human respiratory quotient range from 0.67 to 1.2. Values outside these ranges likely reflect inaccurate measurements and should be repeated. Factors that may impact measurement of accuracy include leaks in the pulmonary gas exchange, such as chest tubes, air leaks in the tubing collection or collection device, pain, agitation, hemofiltration, and ECMO. In the clinical setting, ideal testing conditions are difficult to obtain. Patients are often receiving nutrition support, have changes in medication, sedation, ventilation modes throughout the day. Therefore, the respiratory quotient should be considered a measure of quality control as opposed to that of substrate utilization, for example, over or underfeeding. Often patients that are not actively receiving nutrition support may have a respiratory quotient at 1 or above, which theoretically would indicate that glucose utilization and potentially lipogenesis. However, we know we're not feeding these patients, and therefore this is just a measurement of accuracy. The CV, or coefficient of variation, is the measure of variance between the deepest and shallowest breaths and is expressed as a percentage. In a steady state, minimal variation is seen, and the CV is low, ideally less than 10%. Large variations can occur with pain, agitation, unsteady respiration such as rapid or shallow breathing, and even physical or auditory stimulation, such as televisions or visitors talking in the room. Efforts should be made to minimize or avoid these factors in order to obtain the most accurate measurement possible. Inability to achieve a CV of 10% or less results in invalid measurement, and the test should be repeated at a later time. While considered the gold standard for determining energy expenditure among critically ill patients, indirect calorimetry is not without its own limitations. Because it's difficult to measure small differences between volumes of inspired and expired air, large errors in measurement can occur when the fraction of inspired oxygen, or FiO2, is greater than 60%. Therefore, measurements cannot be obtained from mechanically ventilated patients receiving high amounts of oxygen support. Additionally, delivery of supplemental oxygen, such as through a nasal cannula, a venti mask, or an on-rebreather, will inhibit indirect calorimetry measurements unless able to be weaned for the test. Other considerations when determining ability to perform indirect calorimetry measurements include use of anesthetic gases, leaks in the pulmonary gas exchange system, such as a deflated cuff around the endotracheal or tracheostomy tube, chest tubes and bronchopleural fistulas, poor calibration of the indirect calorimeter and/or inability to validate the equipment, and perhaps the most limiting factor among critically ill patients is lack of a steady state. FiO2 administration is changed throughout the day in efforts to wean patients from ventilation. Changes in medication or enteral or parenteral nutrition, such as holding for tests or procedures, and titrations of formula may impact the reliability of the test. There are two major types of indirect calorimetry, closed and open circuit. During closed circuit calorimetry, the subject is connected to a mouthpiece, mask, or endotracheal tube, which is then connected to a spirometer filled with a known amount of 100% oxygen. The subject rebreathes only the gas within the spirometer. Carbon dioxide is removed from the canister by a canister of soda lime, potassium hydroxide, placed within the circuit. VO2 is then determined by measuring the amount of oxygen consumed from the spirometer, or the amount of added oxygen needed to maintain a constant volume within the canister. Closed-circuit IC cannot be used for exercising subjects as the apparatus gives too much resistance and does not remove adequate volumes of CO2 needed to achieve adequate oxygenation during exercise. With open-circuit calorimetry, the subject breathes through a two-way valve in which room air is inspired on one side of the valve, and expired air passes to the opposite side where it is either analyzed immediately or collected for later analysis. There are several types of open-circuit IC. During the Douglas bag method, expired air is collected in a large vinyl bag for later analysis. Additionally, there are other types of lightweight, portable apparatuses that may be strapped to the subject's back to measure ventilation or periodically collect expired air throughout the day. More commonly used is the computerized metabolic monitor method, such as a metabolic cart. Computerized metabolic monitors have been found to be more accurate, have better reproducibility, are less time-consuming, and easier to operate and analyze than Douglas bag or other bag collection methods. Metabolic monitor measurements can be done at the bedside to measure energy expenditure of spontaneously breathing or mechanically ventilated patients. A variety of collection modes exist, including inline sensors for mechanically ventilated patients, airtight face masks, mouthpieces with nasal clips, and perhaps the most well-tolerated method among free-breathing individuals, a ventilation hood that creates an airtight seal around the subject's head. The volume of inspired and expired air, also known as minute ventilation, is measured via a pneumotech which fits each specific collection apparatus. Within indirect calorimetry units, gas analyzers determine the oxygen and carbon dioxide content of both inspired and expired air, as well as temperature, humidity, barometric pressure, and other factors, which are then used to determine energy expenditure, substrate utilization, and coefficient of variation. Small handheld devices have been designed for use in the outpatient setting and offer a more simple approach to IC. The device is held by the subject securing the lips around a mouthpiece with a nose clip in place for 5 to 12 minutes. These handheld devices, however, only measure oxygen consumption, not carbon dioxide production, limiting accuracy of the results. As previously discussed, indirect calorimetry measurements are time-consuming, labor-intensive, and unavailable at most institutions. Predictive formulas may not correctly estimate energy expenditure. If available, IC measurements should be obtained to accurately assess energy requirements for all patients. These include patients in a hypermetabolic state, such as during critical illness, those who have altered body composition, such as under or overweight individuals, obese individuals, those with unexplained weight changes, altered body composition such as ascites, amputation, or extreme edema upon admission. Additionally, those with non-healing wounds, both surgical and pressure ulcers, should have IC measurements performed when possible. Lastly, those with inappropriate response to nutrition support, such as seen with over and underfeeding, should have IC measurements when possible. When performing an indirect calorimetry measurement, the metabolic heart must be calibrated prior to each measurement. Subjects should be resting for at least 30 minutes prior to testing. An effort should be made to maintain a quiet and thermoneutral environment. The provision of nutrients, oral, enteral, or parenteral, should be constant for at least 12 hours prior to testing, meaning no changes in volume or rate of delivery, or if in a fasting state, food, enteral, or parenteral nutrition should be withheld 4 to 6 hours prior to the test. Routine care such as lab draws, turning blood pressure measurements, as well as administration of medications, particularly analgesics or sedatives, should be avoided within at least 1 hour prior to the test. Prior to calibration of the metabolic heart, the clinician should assess the status of the following variables, as each may inhibit ability to achieve IC measurement. There should be minimal change or no change in mechanical ventilation for at least 2 hours prior to testing. Additionally, the patient should not be in a hyperventilatory state, greater than 35 breaths per minute, with a positive end expiratory pressure, or PEEP, of less than 10, be receiving no greater than 60% of FiO2, and there should be no leaks in the ventilatory circuit, such as from deflated cuffs in the endotracheal or tracheostomy tube. Furthermore, unsealed chest tubes, bronchopleural fistulas may represent leaks in the air exchange system and inability to perform IC measurement. Lastly, the patient should be hemodynamically stable for at least 2 hours prior to obtaining the measurement. Other variables that will prevent accurate IC measurements include infusion of bicarbonate, hemofiltration such as continuous renal replacement therapy or hemodialysis, extracorporeal membrane oxygenation or ECMO, inability to achieve a steady state such as during agitation, pain, or respiratory compromise. And if you're collecting a UUN measurement, it's important to consider the ability of the medical team to correctly obtain and maintain this urine collection within 24 hours of you performing the test. To accurately assess energy expenditure throughout hospitalization, indirect calorimetry measurements should be repeated with changes in clinical status. Obtaining repeated measures can help prevent complications associated with under- and overfeeding. Changes in energy expenditure should be analyzed by the clinician, and subsequent changes to the nutrition regimen should be made as deemed appropriate. In conclusion, indirect calorimetry measurements should be utilized to determine energy requirements whenever possible, especially among critically ill patients. Repeat IC measurements should be obtained throughout the hospitalization to assess changes in energy expenditure throughout the disease or injury process. If predictive equations must be used, careful consideration should be taken to choose an equation, ensuring that the population from which the equation was derived matches the population in which it will be used. Lastly, clinical judgment should be used when assessing the results of IC measurements or predictive equations, with special care to not over or underfeed the patient.